In the area of maternal and newborn health, a number of practices have been proven effective in clinical research. However, the shortage of health workers in high-burden countries means that we are often unable to deliver these critical interventions to mothers and newborns. One of the solutions that has been proposed is task shifting or task sharing. This usually involves shifting or sharing of tasks from one group of health workers to another group who have less training, but that can be trained to provide the required tasks or sharing tasks among different groups of health workers. And because these health workers with less training live closer to the communities or may be available in larger numbers, delivery of these life-saving interventions may be improved. Many countries have asked WHO for advice in the field of task shifting so they may optimize health worker roles and improve access to key interventions for improving the health of mothers and children. Therefore, we have recently developed a set of recommendations focusing on shifting tasks to different groups of health workers in the community or primary care. These guidelines cover lay health workers, auxiliary nurses, auxiliary nurse midwives, nurses, midwives, associate clinicians, and non-specialist doctors. This film gives further insight into the problems and possibilities surrounding optimizing access through task shifting and sharing.
Some people really don't have money to pay for the transport.
The distances to the clinics are the challenges. Also, the commitment to serve from the health facilities, commitment to serve people in a right way.
Many mothers and children rarely receive health treatment. This is often because of a severe lack of health workers or because existing health services are too far away from where people live. One way of dealing with this problem is to shift tasks to health workers who have less training or to share tasks better among health workers. Lay or community health workers could, for example, take on tasks normally done by nurses, such as health promotion or the prevention or treatment of some childhood illnesses. Nurses and other mid-level providers could, in turn, engage in tasks normally carried out by doctors. Task shifting has a number of advantages. One of them is that people often appreciate the opportunity of receiving health care closer to the place they live and from health workers that they know, who they think of as being similar to them in some way.
She's someone you can talk with, you see, and then she will advise you, right, you see, your problems, you see. Then she will show you the way you must go this way, you mustn't do this, you see. This is the way that I was, you see. And now look at me, I'm here, you see. She's so motivated.
I don't want to go to the hospital because the services that we get in the community and the behavior that we get from the community health facility is very nice. I'm telling from my personal experience, when I go to the hospital, when I was in labor pain, then the hospital staff scolded me. They used bad words, so their behavior were not good. So I do not want to go to the hospital.
Our mentor mothers come with an approach to respect mothers and not to judge them. So it's easy for mothers to disclose whatever information they have to our mentor mothers.
The health workers themselves are often pleased to be given the chance to expand their roles, particularly if they receive proper training and support.
It's a good thing for us because we are happy what we are doing, that we are helping people. It's a good thing because don't feel good that we will just weigh a child and left a mother in the bed who is sick or anybody else who is ill and just look after children only.
In addition, many of the health workers who have delivered these tasks in the past appreciate the help they now receive from other groups of health workers.
There won't be a long queues in the clinics. There won't be a stigma to the community. I think that can work well.
But some people are concerned that the transfer of tasks to health workers who have less training might lead to harm.
We have to consider if the health workers who are taking up the new roles are actually capable of doing that or not. We have to consider their capacity to carry out those functions in quality manner. And there should be a proper mechanism to monitor if the health workers are doing that properly or not, if they are facing any problems or not, and there should be a mechanism to support them in case of any problems they face during implementation of those or delivery of those interventions.
First thing that came from a doctor is that, we are trained for such a long time and we are not able to do it efficiently. How will they do? And they were always talking of a possibility of compromisation in quality of the service. Okay, so that is an issue. I'll give you another example. Like, we have started training nurses in making ultrasonic examination of a pregnant lady, and they say that she might come up with something wrong interpretation of the ultrasonic findings. Yes, but what is the instance? What is the proportion of diagnosing correctly, and what is the proportion of misdiagnosing it? We found that they diagnose correctly on most 95% of instances. So the 95% people benefit.
In addition, practical problems such as poor access to training, supervision or supplies may make task shifting to new groups of health workers unfeasible.
Since it's a birthing center and equipments and the supplies needs to be in place, that makes me more efficient in my work and more trainings on new health topics.
Health workers who take on new tasks are sometimes also dissatisfied with their new working conditions.
Anything new meets up with resistance. And often professionals don't want to give responsibilities away to somebody who has less training than them. I'm not sure, what the reason for that is, whether they feel that somehow it diminishes the importance of what they do if someone with less training is able to do a similar thing. I think that may be part of it. And the other concern, of course, is about quality. I don't think that one can view these things lightly. One shouldn't just expect that a lay person can do, whether it's education or case finding or adherence support. I think it's really critical that there's a rigorous training program, a standardized training program, and that the training program is not just once off, but that there are refreshers and that there's some kind of mechanism for quality assurance to ensure that they're able to perform the functions to the best standard.
Another concern is that recipients may prefer more highly trained health workers or may worry about confidentiality.
We also have to consider the social acceptability issues, because some of the services the community may not be willing to get from community volunteers or somebody whom they know. For example, the cases on HIV/AIDS or tuberculosis, which might have some stigma associated, they may want to go with the health workers who is not known to them. So we really have to consider these factors, and we need to customize all of these as per our country need and country situation and country circumstances.
The solutions proposed by these guidelines can be perceived by the public as a cheap solution, and that can create some sort of rejection from the consumers, the patients, and the general public. So these are all evidence-based recommendations, and they are the optimum solution for the delivery of these interventions. And this has to become clear, this has to be clear for the society. These recommendations, they are combating, they are fighting against health inequities, and they're promoting the universal access to healthcare.
To develop the guidance, an international panel of stakeholders systematically reviewed the evidence, weighed the pros and cons of the different options, and arrived at a set of recommendations.
The guidelines were developed through a systematic process, and the WHO convened a group of stakeholders from all over the world with good representation from the South. We looked at the available evidence that had been assembled by the technical team. We weighed the benefits of the interventions versus the harms of the intervention and made recommendations based on these. When the guideline panel was unsure as to the safety of a particular intervention, we recommended that the intervention be carried out in the context of rigorous research or could be implemented together with monitoring and evaluation. The guidelines panel did not always recommend task shifting interventions. For example, associate clinicians, we recommended against doing external cephalic versions or cesarean sections.
The recommendations are options rather than prescriptions or rules. Policymakers and program managers need to consider these recommendations in relation to information from their local setting regarding priority problems, the availability of different types of health workers, costs, and so on, before making a decision on whether to implement.
Guidelines is a framework. So it's not that it's specific, it's just a framework that is given by WHO. It's up to the countries who are implementing it to tailor it as per their need, as per their health system, as per the resources they have, as per the local settings.
Well, one of the interventions we looked at was whether lay health workers could deliver misoprostol to protect against PPH, postpartum hemorrhage. This might be useful in a context, for example, Ethiopia, where there is a widespread network of lay health workers or health extension workers with good referral networks. In a situation where a country doesn't have a good, well-developed system of lay health workers, where there's poor support, poor logistics, this may not necessarily be a good idea.
To help policymakers adapt these recommendations to their own settings, the guidance document has highlighted several factors that can influence the success of task-shifting programs.
To be a success, there are certain things that needs to be in place. The health worker needs to be properly trained and well supported and supervised in the system. The referral system needs to be in place. If a health worker refers any clients to upper health system or health services, then that referral system needs to be in place. So these are the things that I think have to be in place to be a success.
This guidance may encourage governments and organizations to formalize task-shifting initiatives that might otherwise be undertaken in an informal way. Making processes like this more formal is a way to give health workers better protection and support.
We have been doing lots of things that is already there in our country recommended in the guidelines, so it'll help formalize things and it'll open doors for other opportunities also.
In a country like Nepal, which is geographically challenged, we really need to bring the services closer to the community. And sometimes when we need to develop that kind of policies, we need to have proper evidence-based. We need to have supporting documents and guidelines, and this WHO guideline is very helpful to move forward in that direction.
Our overall objective is to ensure that every mother and child who needs attention and care receives the best option. And we hope that the policies recommended in the WHO guideline will help the countries achieve this.